Good morning, ladies and gentlemen. Today, I'm starting a new topic, and this is regarding the systemic therapies. So, this lecture will cover several different tips and management strategies of systemic therapies which we commonly give to our patients in dermatology. So let's start the lecture with introduction. The systemic agents distributed via the cutaneous vasculature have potential to exert their pharmacological actions on all elements of the skin. So once an agent is taken by food or is given subcutaneously or by intravenous route, all the pharmacological actions will be on the whole body, whole of the skin, and all the systems. And not only the skin, but most of the body organs are exposed to that drug and have the potential for significant adverse effects and sometimes life-threatening if the agents which are used are serious chemicals. A latent aphorism means do not harm. It is a sweet reminder to the clinician always to consider the possibility of unwanted and perhaps dangerous consequences of a therapeutic intervention. So it is mandatory for a clinician to decide how much good a systemic agent is going to do to that patient and its disease, and what are the side effects which are expected. So the side effects should be minimum and there should be no risk involved, because even if the disease is not treated, we never want patient to receive some permanent damage because of a systemic agent. Well, it is believed that the clinicians used systemic medications as safely as possible. It's also important to appreciate the patient's perspective and to assess the detrimental impact of a skin disorder on a patient quality of life when assessing the risk-benefit balance of a particular drug. Sometimes the patient is so disturbed with his disease that we have to introduce the systemic agents quite early. But all such patients must be carefully and meticulously briefed about the potential side effects which he or she can encounter while using these systemic agents. The systemic dermatological medications is a treatment, is rarely a cure. We know that most of the dermatological diseases or the serious dermatological diseases requires a lifelong management. So by indulging a patient to a risk of a medication for life needs careful evaluation. The ideal must be a combination of systemic and topical therapy. For this reason, the clinician and patient should try to establish a mutually agreed, achievable therapeutic goals. So being a dermatologist, the topical therapy is our main arsenal. So rather than going for a systemic therapy that has side effects, we should always try to manage the patient on topical therapy on long-term basis. These topical therapies carries minimal risk. What should be done for the further risk reduction? The drug side effects can be divided into those that are predictable due to known toxic properties of the drug and those that are idiosyncratic and therefore unpredictable. With all the drugs we are using in dermatology, we are quite sure about the predictable and idiosyncratic side effects. So both these side effects should be kept in mind. it is largely possible for clinicians to make measures to minimize the likelihood of serious, predictable complications. But even the most experienced and attentive clinician will still be subject to the capriciousness of drug reactions and should be clearly explained to the patient. Notwithstanding, any severe drug-related incident should prompt reflective analysis by the clinician to the possible benefits of future patients. So each new side effects must be noted and notified to the drug company for the benefit of future patients. Standard of care. The astute clinician must consider evidence-based guidelines produced by reputable organizations before prescribing any systemic therapy. And these guidelines are easily seen in the websites of British Association of Dermatologists, American Academy of Dermatology, National Institute of Health and Care Excellence, local policies and protocols. We have a textbook of guidelines published by Paramount Publishers, recommendations of individual pharmaceutical companies for individual drugs. Then patient selection and education. Weighing the potential disadvantages against the potential advantages of a specific drug, that is the risk-benefit assessment, is must for every systemic drug. Active participation of patient and sometimes their relatives and family doctors, this is called as the therapeutic partnership, should always be encouraged in decision-making process. This necessitates the careful patient education, verbal explanation by a physician or a specialist nurse. Once decision on a treatment has been made, patient should be directed to read the package insert that comes with the drug, advise when and how to take the medications, the warning symptoms of severe side effects, and importance of monitoring tests, which will be done as the patient starts taking the medication. Pre-treatment scoring and monitoring. In order to minimize the predictable risk of a systemic drug therapy, it is prudent to undertake appropriate baseline investigations, which include the hematological profiles and biochemistry, and carefully monitor the necessary parameters during the course of treatment. A few systemic dermatological treatments that do not require some form of pre-treatment screening and subsequent monitoring should still be watched carefully by the clinicians. Then another important aspect of systemic medication is the drug interactions. Clinicians are strongly advised when they recommend a systemic treatment to exclude the potential interactions with patients' existing medications. Most of the middle-aged patients are already taking medications for their blood pressure, for diabetes, for heart ailments, and other therapies, even for depression or anxieties. Then to provide patient with list of agents that might interact with the new drug and ensure the patient knows to make the future prescribers of any medication what he or she is currently using. So it is possible that the new drug which you are giving to the patient might interact with patients already using medications, or this drug which you have prescribed to the patient might interact with any future drug which the patient will receive from any other physician. Record keeping. This is the most important. It is advisable to keep a register of patients who are on high-risk therapies so as to identify more readily clinical any side effects and its risk management. Well-maintained records are the best defense against unwarranted criticism. Failure to keep adequate documentation can be interpreted as falling short of expected standard of care. Basic pharmacology of systemic therapy. The dermatological drugs are usually administered by oral, subcutaneous, intramuscular, or intravenous routes, and it is the pharmacokinetic properties of a drug that determine its absorption into circulation, its distribution, the bioavailability at the intended sites, and its metabolism and excretion. Genetic studies are sometimes also important as screening of genetic polymorphism that affect the activities of enzymes like thiopurine methyltransferase and glucose 6-phosphate dehydrogenase G6PD, predisposed to the adverse hematological effects from azathioprine and dapsone, respectively. The immunomodulator drugs. Majority of systemic drugs utilized for dermatological conditions are the immunomodulator drugs, and a number of these drugs exert potent immunosuppressive effects. Prior to initiating the treatment with immunosuppressive agents, patients should be carefully counseled about the risk of infection, systemic and cutaneous malignancies, bone marrow suppression, and conception-related issues. Written information should be provided to the patient. The entire skin should be examined to exclude the presence of dysplastic or neoplastic lesions, and sun protection measures should always be discussed. So these are the suggested pre-treatment checklist for cytotoxic and immunosuppressive therapies. Patient information leaflet, then risk counseling should be done. I've already explained it. Then general skin examination should be done. I've already explained. Then blood tests should be done, like full blood count, urea, liver function, hepatitis serology, HIV serology, varicella zoster virus serology, and history of vaccination, especially the live attenuated vaccines. In order to minimize the risk of reactivation of dormant infections, patients need to be screened for latent blood-borne viruses like hepatitis B, C, and HIV, then latent tuberculosis, varicella zoster virus, immune status. Periodically at follow-up appointments, remind the patient to adhere to sun protective measures. Occasional, perhaps annual general physical examination should be undertaken in view to exclude development of new lymphoma or cutaneous neoplasms. Now I'm going to discuss the individual drugs. The first drug which I'm going to discuss is most important for all dermatologists, and that is antihistamines. Histamine is synthesized by and stored in mast cells and basophils, and its release results in inflammation, which contributes particularly to urticaria. The histamine receptors are exposed in skin on endothelial cells, neurons, and T lymphocytes. Specifically, there are two types of histamine receptors, the H1 receptors and H2 receptors. The H1 receptors, when combined with histamine, produce itch, vasodilatation, and increase vascular permeability, while H2 receptors do not participate in itch, but contribute to vascular dilatation and vascular permeability. In clinical practice, the only effective way of minimizing histamine-mediated inflammation is by use of antihistamines, primarily those that act on H1 receptors and block the H1 receptors. The first generation antihistamines are represented by elimazine, chlorpromazine, clemastine, cyproheptadine, hydroxyzine, and promethazine. So these drugs are Periton in chlorpheniramine, hydroxyzine in Atarex, promethazine in Phenergan. They easily cross the blood-brain barrier and hence cause sedation and impairing the cognitive functions. The second generation antihistamines, which are more commonly used nowadays, they include the acrivestin, the belastine, citrazine, levocitrazine, loratadine, disloratadine, fexofenadine, mesolastine, and reputadine. Among this list, a few drugs are still not available in Pakistan. Such drugs do not cross the blood-brain barrier and hence are minimally sedative. Dermatological uses. The H1 antihistamines are the mainstay treatment for chronic urticaria and angioedema. They are symptomatically beneficial in physical urticarias, in urticarial vasculitis, in cutaneous mastocytosis, in insect bite reaction, in anaphylaxis, and allergic reactions to the drugs. Their effectiveness in atopic eczema remain to be established, but the sedating H1 antihistamines have a role in management of nocturnal pruritus in atopic eczema. A combination of H1 and H2 antihistamines, which is off license, has been advocated for the treatment of chronic urticaria, although the quality of evidence is low. H2 receptor mediated downregulation of T lymphocyte activation is the rationale for the treatment of choice in mucocutaneous candidiasis in human papillomavirus with H2 antihistamine. So H2 antihistamines are also immunosuppressives and hence are useful in these two conditions. Pharmacological properties, the pharmacokinetics. H1 antihistamines differ in structure and in their pharmacokinetic characteristics. In general, they are readily absorbed from GI tract, reaching peak plasma level in 2 to 3 hours, and then substantially are protein bound. The lipophilicity of first generation antihistamines determine their ability to cross the blood-brain barrier, in contrast to the second generation antihistamines. The first generation drugs are metabolized by hepatic cytochrome P450 system, usually followed by predominant renal excretion. A number of second generation antihistamines may be excreted unchanged into the gut, like fexofenadine, or urine, like citrazine and levocitrazine. Then pharmacodynamics. H1 and H2 histamines are now best regarded as inverse agonists, not just blocking the interaction of histamine with its receptors, but by decreasing the constitutive activity of the receptors. They not only bound to the receptors, but also decrease the activity of the receptors. H1 antihistamines, especially the second generations, also have anti-inflammatory effects, which include inhibiting the release of histamine from mast cells and basophils, inhibiting the tissue activation and accumulation of inflammatory cells like eosinophils, and directly inhibiting the pro-inflammatory mediators like bradykinin. First-generation antihistamines have high affinity for muscarinic cholinergic receptors, thereby inducing the anticholinergic side effects as well. Cyproheptadine is thought to have additional anti-serotonin activity and to interfere with hypothalamic functions. Phenothiazines have alpha-adrenergic blocking activity and may cause hypotension. Potential adverse effects. First-generation antihistamines, as I've already explained, cause sedation, impaired cognitive functions, paradoxical excitability, especially in children and elderly on high doses, then anticholinergic side effects like blurring of the vision, dry mouth, micturition difficulties, and constipation, and weight gain. Second-generation antihistamines are generally safe and free from such adverse effects and have high therapeutic index. So it is recommended to use the second generation antihistamines in most of the cases. Rarely, antihistamines may cause headache, hypotension, palpitation, arrhythmias, sleep disturbance, dizziness, confusion, extramarital effects, tremor, convulsion, depression, and hypersensitivity reactions. All such effects are common in first generation. The cardiotoxic antihistamines, which were terfenadine and estimizole, are no longer in use now. Caution. Although the available data do not suggest that H1 antihistamine pose a significant risk to fetal well-being, it is generally recommended that they should be avoided during the pregnancy and lactation unless there is a clearly favorable benefit-risk ratio. And if we are compelled to use the antihistamine, for example, for pregnancy-related pruritus or skin conditions, chlorpheniramine, cetirizine, fexofenadine, and loratadine are generally acknowledged to be safe during pregnancy. The first generation antihistamine, because of the sedative and anticholinergic actions, should be used with caution in patients with epilepsy, glaucoma, prostatic hypertrophy. Warning should be given regarding the concurrent alcohol consumption because driving and operating dangerous machine will become more dangerous. Caution should be exercised if there is severe hepatic or renal impairment, severe hypertension, respiratory problems, porphyria, or predisposition to cardiac arrhythmias. Drug-drug interactions. Cyproterone 3A4 inhibitor, such as macrolide antibiotics, the azole antifungals, H1 protease inhibitors, and grapefruit juice inhibit the metabolism and increase serum levels of those antihistamines that are metabolized in the liver and cause an increase in their adverse effects. So alcohol, anxiolytic, and hypnotic drugs may exacerbate the sedating effect of first generation. Antacids reduce absorption of fexofenadine. Antidepressant drugs like tricyclics and monoamine oxidase inhibitors increase the sedative and antimuscarinic effects of first generation antihistamines. Dose and regimen. If the recommended dose of individual antihistamine is not clinically effective, it's a common clinical practice in case of second generation antihistamine to prescribe a double or triple dose, which are absolutely safe. Furthermore, combination of two or more antihistamines are more effective than monotherapy. Then we have come to another very important drug, which is used frequently in dermatology, and these are the anti-malarial drugs. Quinine, a natural anti-inflammatory alkaloid, is derived from the bark of South American cinchona tree. Its synthetic derivatives with fewer side effects were developed between 1930 and 40. Of these are mepacrine, also known as the quinacrine, chloroquine, and hydroxychloroquine. These agents are employed as anti-inflammatory agents in various clinical settings, primarily the dermatological and rheumatological cases. Mepacrine is now relatively little used, but both chloroquine and hydroxychloroquine are more widely prescribed. Hydroxychloroquine appear less toxic, but also less effective than chloroquine. The dermatological uses. The licensed dermatological indications for antimalarials include the cutaneous forms of lupus erythematosus, photodermatosis like polymorphic light eruption, solar urticaria, and porphyria cutanea tarda. And the off-label dermatological uses include the granulomatous dermatosis like cutaneous sarcoidosis and granuloma annulare, then paniculitides like lupus paniculitis, chronic erythema nodosum, and idiopathic paniculitis. Several miscellaneous conditions, which include Jessner's lymphocytic infiltrate, oral lichen planus, urticarial vasculitis, and reticulate erythematous mucinosis. Pharmacological properties. Administration. Hydroxychloroquine sulfate and chloroquine phosphate or sulfate are administered orally in tablet forms. Pharmacokinetics. Hydroxychloroquine and chloroquine are water-soluble and readily absorbed from GI tract, with peak plasma concentration reached after 8 to 12 hours and widely distributed in tissue and accumulate in liver, spleen, kidney, lung, leukocytes, and within the melanin-containing cells of the skin and the retina. Excretion is largely in urine, but also in bile, sweat, and saliva. Elimination is slow, and maximum clinical efficacy take about 3 to 6 months. Pharmacodynamics, the mechanism underlying the immunomodulating and anti-inflammatory properties of anti-malarials are still incompletely understood. The traditional explanation is anti-malarials are lysomotropic, preferentially accumulating within the lysosomes. The resultant rise in lysosomal pH results in inhibition of proteases and disruption of protein secretion, receptor recycling, and reduced production of pro-inflammatory cytokines like the tumor necrotic factor alpha, interleukin 6, and interferon gamma. So, by incorporating within the lysosomes, the drug, these antimalarials decrease the cytoplasmic release of tumor necrotic factor alpha, interleukin 6, and interferon gamma. Effects of this include reduced antibody production and cell-mediated cytotoxicity by lymphocytes, reduced natural killer cell activity, impaired antigen presentation by monocytes, macrophages, and dendritic cells to CD4 T cells, and decreased chemotaxis, phagocytosis, and superoxide production by neutrophils, thereby down-regulating the immune responsiveness. So there is a wide range of effect. More recently, 4 aminoquinolones have been demonstrated to have a potent and important inhibitory effect of intracellular toll-like receptors, TLR signaling, which may be their principal mode of actions. So the antimalarials also exert complex effect by inhibiting phospholipase A2, thereby reducing the prostaglandin formation, and photoprotection by virtue of being able to absorb the ultraviolet light. Furthermore, antimalarials also have anticoagulant, lipid-lowering, and hypoglycemic properties. Hydroxychloroquine is demonstrated to reduce thrombotic events in antiphospholipid syndrome after binding to annexin A5. Antimalarials have beneficial effect on cholesterol, triglycerides, and low-density lipoprotein levels, and help in reduction of atherosclerosis via the effects on cholesterol synthesis. Antimalarials also influence glucose metabolism, decreasing insulin degradation and reducing the risk of diabetes, possibly by involving the blockade of TLR, toll-like receptors 9. So this is a long list of antimalarial drug interactions. They interact with antacids and choline, cimetidine, 4 aminoquinolones. Antihistamines enhance the effects of hypoglycemic therapy. They may increase risk of ventricular arrhythmias with amiodarone. Then aminoglycosides antibiotics may exacerbate neuromuscular adverse effects in combination with antimalarials. There is a risk of convulsion if used with antiepileptics. Potential adverse effects. The myelotoxicity, although very uncommon, but the antimalarials, particularly chloroquine and mepacrin, suppress bone marrow function and cause leukopenia, agranulocytosis, and aplastic anemia. Antimalarials may cause hemolysis with glucose 6-phosphate dehydrogenase deficiency. Cutaneous toxicity. They are generally considered that anti-malarials, especially chloroquine and mepacrine, result in exacerbation of psoriasis. Antimalarials have also been associated with bleaching of hairs and transverse bands affecting the nail. A mesalliary of adverse cutaneous reactions has been reported with antimalarials, including pruritus, erythroderma, urticaria, lichenoid eruptions, photosensitivity, and alopecia. Then idiosyncratic adverse effects. Oculotoxicity. Antimalarials induce retinopathy and is an important vision-threatening side effect. It appears to be mostly idiosyncratic. The onset of central visual loss may be insidious, and early detection at a reversible stage is important. Once developed, the maculopathy tends to be permanent and even progressive, even following cessation of antimalarials. The most common symptom due to oculotoxicity is the reading difficulty. Risk of retinal toxicity with hydroxychloroquine is small during first 5 years of treatment, but rises to approximately 1% after every 5 to 7 years of use, or a cumulative dose of 1,000 grams. The retinal damage is significantly more common with chloroquine, and the safety parameters are less clear. Hydroxychloroquine is also deposited in the cornea and is usually asymptomatic but may cause visual halos. The corneal deposits are reversible on stopping the drug and are not contraindication to continuing use. The Royal College of Ophthalmologists suggests baseline and annual inquiry to the reading difficulties and reading performance with near vision type test. The American Academy of Ophthalmology produced revised recommendations suggesting using multifocal electroencephalography, fundus autofluorescence or spectral domain optical coherence tomography, in addition to the Humphrey 10-2 static perimetry. So there is a long list of investigations that need to be done. Baseline assessment is always advised with annual screening commencing after 5 years unless there are other risk factors, in which case annual assessment is recommended. The mepacrine is considered to be relatively non-oculotoxic. The neuromuscular toxicity. Rarely antimalarials induce myalgias, fatigue, and myopathy, and are associated with headache, dizziness, tinnitus, hearing loss, nightmares, irritability, seizures, and psychosis. Cardiotoxicity. Antimalarials induce cardiac side effects but are rare, especially hydroxychloroquine, but conduction abnormalities are reported. GI toxicity. Hydroxychloroquine is least likely of the antimalarials to cause a GI symptoms. But if occur, they are nausea, vomiting, diarrhea, anorexia, heartburn, abdominal distension, and elevated transaminase levels. They tend to be transient. The chloroquine and hydroxychloroquine should be used with caution in hepatic impairment. Contraindications. Hypersensitivity reactions to antimalarials are contraindications to their use. Should a patient develop retinopathy, a 4-aminoquinone is continued and its continued use is contraindicated. So if retinopathy develops, then it is contraindicated. Caution. These 4-aminoquinolones readily cross the placenta and is excreted into breast milk as well. Although the risk of fetal damage appears to be low, the use of chloroquine and hydroxychloroquine during pregnancy and lactation is not recommended. Antimalarials should be used with caution in patients with neuromuscular disorders and psychotic conditions. Patient with G6PD deficiency should be monitored closely for hemolysis, although this is unlikely at doses of antimalarials used in treatment of cutaneous disorders. Antimalarials should be given in low dose when treating porphyria cutanea tarda in view of risk of hepatitis. Then pre-treatment screening. Full blood count, liver and renal functions should be undertaken as G6PD level and porphyrin screening. Patient should be counseled about risk of visual damage and provide with written information. If a patient can read small print, N6 or N8, treatment with hydroxychloroquine can proceed. If visual impairment is suspected, assessment by optometrist should be advised. If impairment is correctable by refraction, treatment is started. Non-correctable abnormalities will require ophthalmological assessment before proceeding with hydroxychloroquine. Cigarette smoking is associated with poor response to hydroxychloroquine. Dosage and regimen. Standard dose of hydroxychloroquine for adult is 200 to 400 milligram daily, but not exceeding 6.5 milligram per kg per day. The dose of chloroquine for adult is 2.5 milligram per kg per day based on the ideal body weight. Although there is only limited published evidence, combination therapy of hydroxychloroquine or chloroquine with naproxen may result in enhanced therapeutic response. Monitoring. Full blood count and liver function tests should be checked monthly for 3 months, then every 4 to 6 months. Visual symptoms should be inquired about, especially any problem with reading. The reading performance should be checked annually with near vision test type. Now, the third and again a very important drug is azathioprine. Azathioprine is a potent immunosuppressive, anti-inflammatory, and anti-proliferative drug that has been used over the last 5 decades to prevent graft rejection and treat hematological malignancies and variety of rheumatological, gastrointestinal, neurological, and dermatological inflammatory disorders. The dermatological uses. Azathioprine is licensed in UK for treatment of SLE and dermatomyositis and is used off-label in immunobullous diseases, particularly pemphigus and pemphigoid, in atopic eczema, and in chronic actinic dermatosis. It has been advocated for use in generalized lichen planus or erosive LP, contact dermatitis, polymorphic light eruption, leukocytoclastic vasculitis, pyoderma gangrenosum, Behçet's disease, and chronic cutaneous lupus erythematosus. Its use often as an adjuvant to other immunosuppressive agents such as prednisolone and exerts its steroid-sparing effects. Pharmacological properties. Azathioprine is available in UK as 25 and 50 mg tablet, but in Pakistan it's available in 50 mg tablets only. And it's also available in intravenous preparation, which we rarely use. Pharmacokinetics. The drug is readily absorbed from GI tract, and peak plasma concentration is reached in 1 to 2 hours after oral dose and is distributed readily throughout the body. Plasma half-life is 3 to 5 hours, and 30% is bound to plasma proteins. Azathioprine is a prodrug and is rapidly transformed in vivo into 6-mercaptopurine, which is the active drug. Azathioprine and its metabolites are excreted via kidney and GI tract. A lower dose in case of reduced renal function is necessary. Despite a rapid absorption, metabolism, and excretion of azathioprine, its active metabolites only slowly accumulate in tissue, and thus the therapeutic immunosuppressive effect of azathioprine takes about 6 to 12 weeks to develop. Pharmacodynamics. Azathioprine is a purine analog and the accepted theory that its anti-proliferative, anti-inflammatory, and immunosuppressive effects are the result of incorporation of 6 TGNs, thioguanine nucleotides, into the DNA and interfering its replication, and perhaps also due to suppression of purine synthesis, as methyl thioinosine monophosphate is an in vitro inhibitor of endogenous purine synthesis. All these are metabolites of azathioprine. Azathioprine may additionally induce lymphocyte apoptosis, T cell energy, and possibly modification of CD28 signaling, and thus the immunosuppressive effect of azathioprine may be due to combination of its anti-metabolic and pro-apoptotic actions. The pharmacogenetics. Thiopurine methyltransferase, also known as TPMT, is an important enzyme in the metabolic pathway of azathioprine. Approximately 90% of the white individuals have normal TPMT levels. But 10% of white individuals have an intermediate TPMT activity, which are called as the heterozygous. And less than 1% are those who are homozygous for the TPMT deficiency. Therefore, those individuals who have inherited the TPMT deficiency, metabolism of azathioprine is shunted and the drug takes the direction of excessive production of its metabolites, which accumulate in toxic amounts, especially the 6-thioguanine inosine. Standard dosage of azathioprine in such individuals carries the risk of severe bone marrow suppression and consequent pancytopenia. So conversely, the TPMT deficiency result in reduced levels of 6-MPP, methyl mercaptopurine, exists as 6-MMP is hepatotoxic. Azathioprine-induced liver damage is less likely in those with reduced TPMT levels. Pre-treatment testing for TPMT polymorphism has become a standard practice in UK, either by measurement of TPMT activity in erythrocytes or undertaking the genotyping and result in use to determine the dose of azathioprine. Then the drug interactions. Azathioprine and febuxostat by inhibiting xanthine oxidase, then angiotensin-converting enzyme inhibitors like captopril and enalapril increase the risk of myelosuppression with azathioprine. Azathioprine reduces the anticoagulant effect of coumarins. Both sulfamethoxazole and trimethoprim increasing the myelotoxicity of azathioprine. Then aminosalicylates also increase myelotoxicity of azathioprine. Pharmacological adverse effects. The myelosuppression. Bone marrow suppression is the most likely with intermediate TPMT levels and increasingly likely in individuals with low TPMT levels. However, normal TPMT levels with low 6-TGN production does not negate the possibility of myelotoxicity. Hematological monitoring is therefore always required when giving azathioprine throughout the duration of treatment, independent of TPMT status. Leukopenia is most common hematological side effects, but anemia, thrombocytopenia, and pancytopenia can all occur. So whenever you are ordering the blood complete picture, always look for the WBC count, the platelet count, and the HB. Patient should be warned to report infection, bruising, mouth ulcer, and sore throat, which might be an indication of myelotoxicity. Carcinogenesis. there is a paucity of data concerning immunosuppression-related carcinogenesis with azathioprine in dermatological conditions, but it appeared prudent to monitor the dermatological use of azathioprine for development of lymphoma and squamous cell carcinomas. Infections. Azathioprine therapy is associated with increased risk of infection, particularly disseminated herpes simplex, varicella zoster virus, and human papillomavirus. The gastrointestinal side effects. Nausea, vomiting, diarrhea are common side effects of azathioprine and must be minimized by dose reduction, dose division, and taking azathioprine with food. Pancreatitis is also reported. Then hepatic side effects. Although generally well tolerated, mild derangement of liver function is not uncommon, which requires alteration of dose. However, azathioprine can rarely cause severe and life-threatening hepatitis. So the liver function should always be monitored throughout the treatment with azathioprine. Then idiosyncratic adverse effects. This is the hypersensitivity syndrome. Azathioprine hypersensitivity syndrome is rare, but potentially fatal adverse effects. Occurs in 2% of patients treated with AZA and typically develop early in course of treatment, usually in first month. The syndrome is characterized by fever, malaise, arthralgias, myalgias, nausea, vomiting, diarrhea, and occasional renal and liver dysfunctions, pancreatitis, hypertension, cardiogenic shock, and leukocytosis. In majority of cases in which rash is a feature, the clinical and histological features are also of neutrophilic dermatosis that resembles sweet syndrome, erythema nodosum, acute generalized exanthematous pustulosis, and leukocytoclastic vasculitis. Contraindications. Azathioprine is contraindicated if TPMT level is low. If there is history of hypersensitivity to AZA, in presence of severe infections, with severe hepatic or bone marrow functions or pancreatitis, with concomitant administration of live attenuated vaccine, it should not be given. Women who are pregnant or considering conception, unless the benefit of giving the drug outweighs its potential risks. Caution. Azathioprine is not recommended in breastfeeding women. Men taking azathioprine should also receive counseling regarding the possibilities of reduced fertility and teratogenicity. Then pre-treatment screening. A full blood count, including WBC, kidney functions, and liver functions. Renal impairment requires a dose reduction, and hepatic dysfunctions also necessitates close supervision of hematological and liver parameters. Pre-treatment assessment of TPMT, genotyping, or phenotyping status is recommended to minimize the potential life-threatening side effect of myelosuppression. The dose and regimen. For individuals where TPMT activity is normal, standard dose of azathioprine is 2 to 3 milligram per kg. If TPMT is in an intermediate range, recommended dose is 1 to 1.5 mg. Use of azathioprine is avoided if TPMT activity is low or absent. Monitoring. The liver function test and full blood count should be checked weekly for 4 to 8 weeks after initiating the therapy and after any dose increment. Once the dose is stable, then it should be checked 2 to 3 monthly. Macrocytosis is a common unremarkable feature of azathioprine and should be ignored. Cyclosporine is another important drug which we use in dermatology. It is highly effective and rapidly acting potent inhibitor of T cell function. The importance of cyclosporine is rapidity of its action. Dermatological use. Cyclosporine is licensed for its use in plaque-type psoriasis and atopic eczema since 1990. But the off-label uses include chronic urticaria, pyoderma gangrenosum, hand eczema, and palmoplantar pustulosis. It is used sporadically for a variety of inflammatory conditions like Behçet disease, like lichen planus, prurigo nodularis, chronic actinic dermatitis, and TEN. Pharmacological properties. Cyclosporine was first detected in 1970 in the spores and hence named with the suffix sporin. The fungus is the Tolypocladium inflatum. A hydrophilic microemulsion formulation is developed later. The drug is given orally in dose range from 2.5 to 5 mg per kg daily in 2 divided daily doses. Pharmacokinetics. Absorption of cyclosporine from GI tract is incomplete and variable and depends on individual patients and the formulation. The absolute bioavailability is poor, around 25% of administered dose, due to excessive first-pass metabolism. If taken with high-fat meal, bioavailability is further reduced. Cyclosporine undergoes extensive metabolism mainly in the liver via cytochrome P450, A3A4, all metabolites up to 25. Retain the intact peptide structure of parent compound and some possesses weak immunosuppressive activity. Excretion is primarily biliary. Of total oral dose, around 6% is detected in urine, a fraction of which is unchanged, and renal impairment thus have only a minimal impact on pharmacokinetics of cyclosporine. Pharmacodynamics. It's a prodrug that becomes active only after forming a complex with an intracytoplasmic immunophilin protein known as the cyclophilin. The cyclosporine cyclophilin complex inhibit the calcineurin phosphatase. Inhibition of calcineurin phosphatase and possibly also JNK, Jansen kinase inhibitor, and P38 pathways suppress production of interleukin 2, interleukin 4, interferon gamma, transforming growth factor beta, and upregulation of receptors such as interleukin 2R or CD25, which is the key regulator of T cell activation. Additional actions include reduced histamine release and downregulation of high-affinity immunoglobulin E receptors on mast cells and basophils. Potential adverse effects. There are a large number of potential adverse effects reported with cyclosporine, with hypertension, nephrotoxicity, hyperlipidemia, myalgias, and headache being the most common. Less common are gingival hyperplasia, fatigue, GI disturbance, tremor, paresthesias, and variety of metabolic abnormalities like hyperbilirubinemias, hypercalcemias, hypomagnesemias, and hyperuricemias. Most are dose-related and respond rapidly to dose reduction or treatment cessation. In general, though, cyclosporine is a well-tolerated drug when used for short-term, 6 to 12 months, whereas the long-term use carries significant predictable risk, particularly the nephrotoxicity, and generally not recommended if other interventions are available. Hyperlipidemia. Triglycerides and less commonly cholesterol levels may become elevated within 2 weeks of the treatment and usually returning to normal after withdrawal of the therapy. If hyperlipidemia does require active management, fibrate may be preferred due to increased risk of statin-induced myopathy. Nephrotoxicity. Now, the acute nephrotoxicity occurs within weeks of the treatment, is reversible and arise due to dose-dependent vascular dysfunction of the afferent arterioles, resulting in decreased glomerular filtration rate. Tubular dysfunctions also occur and characterized by decreased magnesium absorption, decreased uric acid excretion, decreased potassium secretion, and distal tubular acidosis. Chronic nephrotoxicity is largely irreversible and characterized by progressive arterial hyalinosis, interstitial fibrosis, tubular atrophy, and glomerular sclerosis. It is more likely to occur with higher daily and large cumulative dose and long-term therapy of 1 to 2 years. Particular risk factors include age over 50, pre-existing hypertension or renal impairment, concomitant treatment with NSAIDs and other nephrotoxic drugs. Intermittent rather than continuous therapy is widely cited as a sensible dose minimizing and side effect minimizing strategy. Malignancy. Long-term use of immunosuppressants like cyclosporine is associated with increased risk of developing certain type of malignancies, particularly the non-melanoma cancers of the skin and lymphoid system. Data from psoriasis cohort indicate the incidence of non-melanoma skin cancers, particularly SCC, is significantly increased risk with use of cyclosporine, predominantly those who have previously received PUVA. Contraindications. Cyclosporine is contraindicated in uncontrolled hypertension, renal disease, serious infections, and those with previous history of malignancy include BCC or high cumulative dose of PUVA. Caution. In women planning conception and during pregnancy, cyclosporine has relatively favorable risk-benefit profile, especially when compared with other agents like methotrexate and retinoids, and is not teratogenic. However, the data from transplant population indicate an increased risk of preeclampsia and low birth weight, so it should only be used where benefits of its use outweighs risks to the fetus. A small amount of cyclosporine is excreted in breast milk, and there are no side effects for breastfed children exposed to cyclosporine. However, the recent European psoriasis guideline suggests that breastfeeding on cyclosporine should be avoided. Drug-drug interactions. Co-therapy with rifampicin, which is again a potent cytochrome inducer, increase cyclosporine metabolism and reduce efficacy. Conversely, erythromycin, which inhibits cytochrome, thus increase cyclosporine level up to 7-folds and with increase to risk of toxicity. So rifampicin reduced efficacy and erythromycin increased efficacy that leads to toxicity. Cyclosporine-mediated inhibition of statin metabolism is a likely mechanism underlying risk of rhabdomyolysis. Grapefruit juice increased cyclosporine bioavailability. Pre-treatment screening. A full history and examination should focus on past or current infections, malignancies, renal disease, liver disease, excess alcohol, and previous phototherapy, especially PUVA. Investigations include full blood count, fasting lipids, ALT, AST, gamma GT, bilirubin, and compressive renal assessment include urine analysis, urine protein creatinine ratio, baseline creatinine, urea and electrolytes, including potassium and magnesium, and urate level. As with all immunosuppressive agents, cyclosporine may enhance the adverse and toxic effects of live-attenuated vaccines, and in addition may diminish the therapeutic effects of the vaccines. Dosage and recommendation. Patients start treatment with lower dose, that is 2.5 milligram per kg per day, escalating to higher dose up to 5 milligram per kg per day after a month, and in an event of poor response. In circumstances where disease is acute, severe, and unstable, treatment may be started with 5 milligram per kg per day, but carries risk of side effects. Lowest possible therapeutic dose should be used to maintain remission. Ideally, a treatment course should not last more than 1 year. Monitoring. In dermatology, routine measurement of drug level offers no specific advantage. Blood pressure, full blood count, liver function test, and renal functions are checked every 2 weeks for 3 months after initiation and after any subsequent dose increase. Once established on therapy, they should be checked 8 to 12 weekly, although fasting lipid may be monitored less frequently. If the creatinine level rises by more than 30% above the baseline, the dose should be reduced, and if it failed to normalize, the drug should be stopped. Drug-induced hypertension should be managed. Calcium channel blockers are preferred first line due to their vasodilatory effects on afferent arterioles. ACE inhibitors may be used, although they lead to certain rise in serum creatinine. Potassium-sparing diuretics should be avoided since cyclosporine tend to increase serum potassium levels. So, summary. Cyclosporine remain an extremely useful, predictable, effective, and generally well-tolerated drug for short-term use. And in those cases where a rapid mechanism of action is required. Long-term use is complicated by nephrotoxicity as well as risks associated with ongoing and potent immunosuppression. So I'm going to end my lecture here, although I wanted to discuss a few other drugs, but the lecture has already gone very long and I'm also tired. So see you next time with the next edition of the same topic. And since this is a large topic, I think we will be able to cover it in 3 to 4 lectures. Thank you very much for patient listening. Goodbye and have a very good day.